So if a patient comes to you with these kind of symptoms, that is the has pain, swelling, and sometimes maybe a snapping or locking or catching with the knee joint, how do you diagnose the patient as meniscal injuries or other associated injuries like ACL, PCR, or even the extra articular ligamentous injuries like LC or MCL injury? So what is important to know is there are certain tests which are done on the knee joint which are more specific for meniscus, as we have, for example, anterior drawn Lachman is always more pathognomic of an ACL injury. Similarly, we have a McMurray test. This is actually called as which is pathognomic of a meniscus injury. How is it done? One way of doing it is that you flex the knee, you internally rotate or externally rotate. So when a doctor is actually internally rotating, at this stage patient is actually mainly checking the lateral meniscus, while when the doctor is externally rotating, that time when he or she is actually checking the medial meniscus. So either in internal rotation or in external rotation, from a flexed knee is actually brought back into extension with the valgus stress. If you can appreciate it over here, the patient is holding up here and this hand is actually on the medial and the lateral joint line. If there is tenderness, that patient will have that kind of tenderness over on the medial and the lateral joint line. So one hand of the examiner is on this side, the other hand is actually used to rotate the calcaneum. Now if the calcaneum is on the inner side, this means it's externally rotated, the leg is externally rotated, therefore you're checking mainly the medial meniscus. And if the calcaneum is on the outside, this means the leg is internally rotated, therefore we are checking the lateral meniscus. The valgus stress is being produced by the body as well as using the hand in this way. And from the flexed knee position, the knee is actually brought into the extension. And if there is pain, either in the internal or external rotation, that means there is either injury of the medial or the lateral meniscus. Now this was the way it was being checked, the lateral meniscus. Now this patient same has been checking the, you can appreciate the knee calcaneum is going out, therefore this is actually checking the lateral meniscus. And this is how you assess it. You internally rotate it, and you from flexion to extension you bring it back, and then you check the lateral meniscus. Then again you flex the knee, externally rotate it, and bring it back to extension and check the medial meniscus. And if there is any tenderness during any of the maneuver, this means the problem is in that meniscus and there is some pathology of that meniscus. This is one of the tests. Some other tests includes grinding test, also called as Appler's grinding test as well. Now this is actually, there are two ways of performing this test. There is another test called as the Saleh test as well, which is rarely done because it only checks a posterior horn of both the meniscus, and that can only if there is a tear of the posterior horn of medial lateral meniscus. The Saleh test will only diagnose that, but grinding test can diagnose all the anterior, middle as well as the posterior horn involved. All the whole of the body can be used to diagnose it. One way of doing it is that patient is actually lying prone. If you see it over here, the patient is lying prone. The examiner's leg is on the posterior aspect of the thigh, therefore he or she cannot lift this leg, and actually the examiner is pushing downwards, which can be appreciated over here. Therefore, as actually called as grinding, when you push forward and then you rotate internally and externally, as if the meniscus is actually grinding in between the media and between the tibia and the femur. As a result, if there is a meniscus lesion and the medial and the lateral side, there will be painful sensations being produced during this grinding test, especially if the person is internally or externally rotating. Depending upon on which side the painful sensation has appeared, usually grinding test can be positive for medial or lateral meniscus. Another way of classifying this problem is called as distraction test. Instead of examiner pushing it downwards and making sure that the meniscus grind between the femur and the tibia, one way is called as the distraction test. All those things stay the same. Patient is prone with the knee on the top of the thigh, which means now when the examiner lifts the leg of the patient, this will not come off the surface, and instead of grinding it, it actually distracts it, so the ligaments become tight. And if there is anything in between, or for example if there is a bucket handle tear, it will actually come off and create more painful sensation. And then the patient examiner internally and externally rotates. Therefore, this is another way of actually assessing the type of a lesion as well. And after grinding test and distraction test, there is a McMurray test. We can also perform the Saleh test as well. This is simply can be performed by asking the patient to bend the knees up to 20 to 30 degrees. And once the patient's knees are bent by 20-30 degrees, the main force is transmitted to the posterior horn. And then the patient has to rotate internally and externally one by one on each knee. And if the pain has been produced by internal and external rotation, this means either the medial or lateral meniscus is damaged. Now we have clinically assessed the patient, and if we are suspecting it's a meniscal injury, then as in our case, the x-rays was normal. Usually in the case of meniscus, if in the isolated meniscal injuries, x-rays are absolutely normal, unless they are associated with some form of a fracture as well. If there is associated tibial spine fracture, then only you will have a lesion on the positive on the x-rays. Otherwise, if an isolated meniscal injury, x-rays may be absolutely normal. Therefore, we need to go for some other form of investigation, and that is in most cases is always the MRI. MRI is the study of choice. Why we need to have sagittal and conal views of the meniscus? Because usually when we are having a sagittal view, we can appreciate a classical triangular shape lesion which is called as meniscus. If you see it over here, can you see anything wrong in the substance? There is absolutely normal. This is the inner side. This is the white zone, this is the red-white zone, and this is the outer 1/3, or called as the red zone. But if you see on the other side, and probably this is medial and this is the lateral, if you can appreciate it over here, this triangular stuff is gone. This writhing of the almost the elements of the meniscus, and you can probably see another double PCL sign as well, which is actually classical presentation. A double PCL sign usually presents actually injury of the bucket handle tear of the medial meniscus. And if it's a double anterior horn sign, this is usually classical presentation of bucket handle tear of the lateral meniscus. So what is important is, in our case, he also had a bucket handle tear of the medial meniscus as well. And therefore, the MRI becomes of utmost importance, because it not only rules out exactly how much is the grade of injury, whether it's grade 1, grade 2, or grade 3, whether it is associated with any other pathology as well, there is associated anything present in the knee or joint as well or not, and is it an isolated meniscal injury, or is it associated with ACL, PCL, other ligamentous injury as well. Therefore, MRI is usually the study of choice and helps to actually not only differentiate what type of injury it is, and also we are able to grade the injury as well. Therefore, for proper planning of the proper planning and execution of the treatment of meniscal injuries, we need to have an MRI, so we exactly know what is the details of the injury inside. Before we go for the confirmation of diagnosis, we have to keep certain differentials in our mind as well. First and foremost is always the loose bodies. Why? Because usually the loose bodies also have these kind of similar symptoms, especially the mechanical symptoms of meniscus injury mimic the symptoms of the loose bodies as well. Certain loose bodies may get trapped during certain flexion extension of the knee and may present with this kind of a snapping sensation in which there is the catching or locking of the knee joint. Or we can have sometimes due to effusion, there may be associated hypoplasia of the lateral femoral tibial condyle as well. Therefore, we need to rule out if there is associated recurrent dislocation of patella or not. And then there may be X-rays usually are normal, but if there is associated fracture of the tibial spine due to any avulsion injuries of ACL, RPCL, or meniscus, then this may be associated with, which may be present on the X-ray as well. And fracture of tibial spine usually produce hematoma. There is always pain, swelling, as well as the symptoms which mimic the meniscal injuries. And there may be associated other ligamentous injuries as well. There may be partial tear of medial collateral ligament or lateral collateral ligament, or we may be having isolated meniscus injury or associated ACL injury as well. Now, the injury of meniscus may be isolated or it may be associated with ACL injury. We need to be sure whether this meniscal injury is not associated with ACL injury, because the ACL deficient knee is more prone to meniscal degeneration. For example, if the patient had a history of trauma in which there is an acute setting, there was a massive swelling, patient had severe pain, and patient was unable to carry out his or her game actually and complete the game. Therefore, if the patient was unable to bear weight immediately, most likely there was associated ACL injury along with the meniscus injury. Therefore, we need to have an MRI to be absolutely sure, because unless we do not reconstruct the ACL, meniscectomy, partial meniscectomy, or even meniscus repair is of no use, because that will eventually lead to ACL deficient knee, would eventually lead to degeneration of the meniscus despite the treatment of the meniscus injury. Therefore, what is imperative that we need to keep these differentials in our mind. There could be meniscus injury, or it could be simply loose bodies, recurrent dislocation of patella. There could be a fracture of the tibial spine, partial tear of the medial collateral ligament, or there could be torn ACL. Depending upon if it's an isolated or associated injury, you need to deal with it accordingly.